Hello, everybody, and welcome to the AHF Podcast. I'm your host, Joe Schwab. Few topics in modern hip surgery seem to strike up as much controversy as hip resurfacing. Hip surgeons have been trying to solve this since at least as far back as the 1920s, with both Marius Nygaard Smith-Peterson in the US and Ernest Haygroves in the UK independently reporting on work they had been doing to restore function to arthritic hips using things like glass and ivory. We've seen mold arthroplasty, cup arthroplasty, double cup arthroplasty, and more, using materials from acrylic to Teflon to stainless steel and cobalt chrome. With the introduction of more modern metal-on-metal implants like the Birmingham hip resurfacing or the Conserve Plus starting in the mid-1990s, hip resurfacing seemed to undergo not only a renaissance, but a considerable spike in popularity, thanks to the purported advantages of bone preservation, anatomic restoration of joint mechanics, and a very stable head-to-shell ratio. With renewed interest, however, came some renewed scrutiny. And with a growing number of designs on the marketplace, it was clear that small design differences were associated with substantially different results. Some designs, like the ASR, were seeing 10-year revision rates nearing 50%. Failures associated with the bearing surface materials seemed to be a common theme, though, to be fair, not all designs exhibited the same problems. So why do we come back to this concept year after year, decade after decade? That's the question for my guest today. Professor Justin Cobb is an orthopedic surgeon and chair of orthopedics at Imperial College London. Not to mention the fact he's been orthopedic surgeon to Queen Elizabeth II as well as King Charles III. But most important to our discussion today is that he's been working to develop the H1 ceramic-on-ceramic hip resurfacing, and with that, he hopes to be the surgeon who finally cracks the code for a reliable, reproducible, and durable hip resurfacing implant. Professor Cobb, welcome to the AHF Podcast.
Joe, you're very kind. I'm delighted to be here.
So depending on who you talk to, hip resurfacing is either potentially the pinnacle of all hip surgery, or it's an unmitigated disaster. Could you put hip resurfacing in a context that seems reasonable for the rest of us?
Yeah, so I really got convinced about hip resurfacing when measuring function in our gait lab. And we looked at, I was very keen on resurfacing from, I guess, around about 2000. It felt like a more conservative procedure. But as you pointed out, many surgeons never really got on with it. One of my friends, who's a very good hip surgeon, thought it was the invention of the doll. And we really had parallel practices, same patient groups. I was resurfacing, he was replacing. I got a grant paid for an instrumented treadmill so we could see how people walked, how they went faster and faster. And we weren't, I think I can safely say, nothing I've done has ever been the first in its field, but we showed what other people have shown, which is that healthy, normal people have got this fantastic, continuously variable transmission gearbox in their brain. And when you put your foot on the gas and walk faster and faster, your stride length and your cadence smoothly increase until you start to run. Mm-hmm. And what we find with healthy adults is that's what happens. In their 30s, 40s, 50s, 60s, 70s, 80s even, that's what happens. If you've got a stem in your femur, that doesn't happen. Mm. Strolling is great. On the catwalk, nobody can tell. But if you want to put your foot on the gas, the person with a hip replacement with a stem in their femur, and I don't think it's really, I'd love to say it's just because of the anterior posterior approach. It does seem to be the stem in the femur, I think. With a stem in your femur, once you start to stress the elasticity of the femur, it doesn't feel, people don't report pain, they just don't do it. Yeah. So they don't push off so hard with the stem in their femur. But the resurfacing's huge posterior approach, taking down G-max tendon, huge approach. A year later, they're walking very, very close to normal people in a way that no one's ever published a total hip that can do that. So that was data I was around. This was in the early 2000s. And it was really exciting, the stuff. But as you pointed out, the metal-on-metal debacle meant that all of these patients who were doing great if you did it accurately, they were okay, but there was a growing feeling across the whole world that metal irons were bad.
Yeah.
And so it was increasingly difficult to persuade people to have a procedure. And certainly in Britain, there was an advisory. You had to have a metal iron level test every year, implying that you had a prosthesis that was about to explode. And so the metal work, it was never going to be widely adopted around the world, as you found out. But functionally, the total hip industry has done I mean, as you know, in the Anterior Hip Foundation, I'm a huge fan of, the insult to the patient for anterior hip surgery is minimal, but in the end, it's a hip replacement. And if you cut out someone's calcar, which is the strongest bit of the whole femur, and you depower that calcar, you don't let the femoral head take all the force coming from your flexors and abductors. If you depower that, then you're changing the biomechanics irreversibly. Whereas if you just resurface the hip, you can allow that femur to perform like a normal femur. And I think that's the difference.
So this is interesting because when I look online at discussions, for instance, every once in a while you'll see a post on LinkedIn where somebody puts up an x-ray of an arthritic hip and says, should they get a total hip? Should they get a hip resurfacing? And the discussion always comes down to recovery, with many surgeons feeling like the recovery is simply easier with a hip replacement than it is with a hip resurfacing. But it sounds like you're talking more long-term functional recovery with people going back to normal as opposed to what happens in the short term. Is that right?
I was. Until a couple of years ago, I would have said what you said is absolutely right, that with an anterior approach total hip, you're up and going very, very fast. And with a resurfacing, you're a bit slower off. You probably are a bit slower. I'd say with anterior resurfacing, I don't think there's a significant, I think if anything, the resurfacings are a bit quicker.
Well, and that actually brings up the other part of the discussion that I usually see is when somebody talks about a resurfacing, it's almost placed as an anterior approach and hip resurfacing are at odds with each other. They're competing products, so to speak. But I mean, really, what you're talking about is doing the surgical approach of an anterior approach to put in a bone-conserving hip resurfacing implant. Is that correct?
That's right.
Yeah.
That's right.
So how do you think we should approach that discussion with those surgeons, online about anterior approach sort of versus hip resurfacing?
So you and I, as surgeons, we know we really can only sell the shoes in our shop. And if you can't do an operation, you brief against it pretty vigorously.
Yeah.
If you're a key opinion leader for a total hip arthroplasty, you better not promote something that the company that is paying you big bucks doesn't even have in their arsenal. So I think the online chat is, some of it is real truth, if you like, people talking from their own personal experience, and some of it is industry-based noise / testosterone-fueled egos.
That brings me to the H1 specifically, because one of the things that you've been working on is the development of this product. And first of all, can you tell our listeners a little bit about the product and a little bit maybe about the release schedule for it? Because it's not available everywhere at this point. Is that correct?
It's not available anywhere at this point, unfortunately.
Right.
I mean, so Derek McMinn, who's obviously very senior and august, but nevertheless dear friend, Derek, when he was developing the Birmingham, in I think 6 years, went through 5 major changes, cementing, uncementing, different designs. These days, so we started with H1 in earnest with Ceramtech in 2013.
Yeah.
And really working very hard to get it into people. We got our first patient the summer of 2017, and we got a CE mark September of last year, and we expect it will be released in, we hope, 6 different European countries, including Switzerland, this autumn. So that the program of regulation is just brutal. It's absolutely brutal. And I'm very sorry, the FDA, when we last spoke to them, they'd all just had a letter from Elon Musk saying, "What are you doing every day?" And
yeah.
and we were speaking English and they were speaking American, and it was a very uncomfortable experience. I mean, I've never had that experience before. Very uncomfortable.
So let's talk a little bit about the H1 itself, because like you said, you partnered with Ceramtech. And so the prosthesis itself, the bearing surface, is the Biolox Delta, right?
The device is monolithic Biolox Delta, which I've been using. Actually, I was very happy with Forte before Delta came along. But Delta now, we've got, I think there's 13 or 14 years of experience and tens of millions of people with Biolox Delta in their bodies. So it seems like it's quite a safe material. And so we felt very comfortable going to them. So they machine the device. It's then coated in a Medicoat. Medicoat was set up in just outside Zurich to coat. Actually, was set up by Heike Grunner to coat the furlong HA coated hip back in the 80s. And his son Philip runs the company now, and they've been coating titanium for a very long time. And coating directly onto green machined ceramic that is new, but it seems to be if you do the testing, you can rip it off, you can shear it off, and the forces needed to take it off are a bit greater. Well, that's the equivalent order of magnitude to ripping off plasma spray titanium from titanium or cobalt chrome. It's a very, very strong bond. But I don't want to talk about adhesion science. It's very, very niche. It's way outside orthopedic surgeons' pay grades.
But suffice it to say, you're putting these in without the use of cement, correct?
So both sides. So I had good experience with cementless metal resurfacing, and Paul Boulet in Ottawa, who's a real giant in this world. He's got, again, very good experience with the Conserve Plus cementless. Tom Gross with cementless recap in South Carolina. Kunda Smith in Ghent has had, I think he's done all 3 of those cementless. And it seems as though the cementless femoral component, it's a safe construct. And so we have the experiment of plasma spray titanium on ceramic on both sides, so a single experiment, whereas we felt that going to cemented, that would be an experiment too. No one had ever got a device cement onto ceramic. That would be a new one too.
Why ceramic as the bearing surface? I mean, presumably there are a number of different options you could have considered. Why did you choose ceramic?
Yeah, so initially, the first thing that came along was the contour. So in the old days, in fact, in the current resurfacings, and with total hips too, groin pain is a thing in hip arthroplasty, and it's between sort of 3 and 5 times as commoner in resurfacing arthroplasty. And that's partly, it looks like it's mainly the acetabular rim. It looks like if someone's got groin pain, you probably didn't get that anterior rim inside the pelvis enough. And we, back in 2007, and actually one of my PhD students we looked at the contour and we realized it was quite a mathematical contour. And so we patented that in 2007. And I wanted to do it with metal on metal, but as we were doing it, was obvious metal on metal was going nowhere. And so a contour metal on metal was never going to run. So we then looked at the different materials. And as I'm sure you know, the Polymotion is in use in North America right now. There's an IDE going on in North America, which is a metal on highly cross-linked poly. But what we, in our preclinical testing, um, one of the things about the group of people who really benefit from resurfacing are the young, very active men with cams, all of whom have quite shallow sockets, and the young, very active women who some have got cams, but quite a lot haven't. They've just got a bit of dysplasia, quite a shallow socket, and so you have to have the opportunity to leave some substantial amount of uncovered bone, uncovered prosthesis laterally to give them the good articulation. And that unsupported polyethylene, the preclinical testing, it just fails it. So we unsupported metal backed, it doesn't fail it, but without metal backing, we couldn't get polyethylene to succeed. So we had to go to hard on hard. And in Europe, I think in every country in Europe, ceramic on ceramic is a well-established bearing couple. It's only really North America that doesn't accept that as a regular thing. In Europe, we've all got really good experiences, I think, of ceramic on ceramic bearings. And so we went to that. And in fact, the unsupported rim, you've got to have the ability to have a cup that is unsupported in mild or even moderate dysplasia. That is not going to fail.
So do you think the reason, is the primary reason that the cups were sort of exposed anteriorly, or groin pain was occurring anteriorly, more common in resurfacings, because of the material, because of the shape of the device, or because of the size of acetabular prosthesis relative to a more conventional total hip, or a combination of those?
Combination. So I'll send you a nice picture showing the acetabular component of a metal one and our contour. And the fact is, if you haven't got a cutout for the iliopubic recess anteriorly where the psoas comes, and the ilioischial, it's a much more gradual recess posteriorly. If you haven't got those cutouts, you've got to put the socket a long way further in to avoid conflict. We can leave the center much more where it wants to be with the contours. So I think it really makes a substantial difference to the surgeon trying to get the socket in the right place. Because it doesn't have to overhang, except to give you back your where the wear scar was. You've now got a lovely big peninsula there, but you haven't got overhang for psoas anteriorly.
Interesting. So you briefly mentioned indications, and let's talk about this, because indications over time for hip resurfacing kind of shrank substantially, from everybody can get it to maybe males with a larger bone size and they're who are very active in their 50s to 60s, 40s to 60s. It's different depending on the literature you look at. But certainly over the last 20 years, the relative indications for a traditional hip resurfacing contracted. From your perspective, and with the development of the H1, does it address some of the reasons for those changes in indications? And what are your indications?
So it wasn't so much the indication, I think, is the truth of the matter. The problem was edge loading of the wear scar in a metal-on-metal bearing. That was the problem. That was the only problem. And and I've got several very prominent female athletes and dancers and so on who are 10 and 15 years after resurfacing, doing just great. But you had to get the socket orientated right. You didn't get it right. They got high metal ion levels. And Tom Gross has published on this, and he's a real master of this. So the indication in women is very strong. If there isn't a contraindication, the contraindication of a uniform thickness metal bearing couple means you've just got this very small surface area on the smaller sizes. With ceramic on ceramic, the rules are completely different. With literally, I think, with millions of ceramic on ceramic bearings, with decades in humans, the case report of edge loading of runaway wear has yet to be published. And because we all love bad news, we all love bad news. If there was bad news, the ceramic consoling haters would be putting up pictures of edge loading and runaway wear on every talk they gave.
Yeah.
But it seems to be a much more benign tribological environment. So the worry about edge loading and runaway wear doesn't seem to be there. And so for women, resurfacing is a great option for women. It really is. It's fantastic. And unlike the sporting, athletic man, women live forever. Okay, they're never going to die, and to cut large bits out of them unnecessarily seems like a big mistake. So our indications are adequate bone mass, and the one thing that gives me the heebie-jeebies is bisphosphonates. Someone who's had bisphosphonates preoperatively, I think that's that's a difficult. I think it's just too scary for us right now. Yeah. But if someone's got, if they're a healthy adult, that means that we know Wolff's Law carries on working in your 90s and 100s. You know, if you're active, you keep your bones active. Yeah. So in our trial, we had 70 as the upper age limit. And I had one built, muscular Californian man who literally sent money he was 72, trying to bribe his way onto the study. And so since the trial, I mean, people in their 70s, as you know, there are lots of really good people in their 70s.
Yeah.
And to say to them, no, you've got to have your femoral head and neck cut out, and someone bang a big bit of metal into their femur. Well, you know, you don't have to have that, I don't think.
I suppose. How about things like certain types of pediatric hip deformity? So you said adequate bone stock. Is that just dealing with osteoporosis or things like Perthes, advanced Perthes, and
so the planning? I mean, we've done a really difficult Perthes is really difficult.
Yeah,
it's really hard. Of course it is. And so there's some things that are just too difficult, and you can't do very much with people's, you can't do what you can do with an SROM with resurfacing. Yeah. Of course you can.
For sure.
But I have done corrective osteotomies and resurfacing simultaneously with fractures of the proximal femur. I think that's something you can do, and just resurface the femoral head. But I think in bad Perthes, I mean, and bad AVN too, of course, you can't use it for those things.
So do you look at version of the femur? For instance, when you're planning for a hip resurfacing, would you correct femoral version? Or obviously you're not going to do that through the prosthesis, or do you just prefer to put them where they anatomically came from?
So it's a great question. And in really bad DDH with huge femoral anteversion, in my old days of metal on metal, I, on a couple of occasions, did a derotation osteotomy of the femur at the same time as doing the resurfacing. I haven't seen, it's a real question, but I just haven't seen that for a while.
Yeah.
But I think the rules are the same in all arthroplasty. You've got to give somebody a biomechanically sound reconstruction, which may require corrective osteotomy.
I think the kinematic alignment total knee folks are challenging our conventional wisdom as to what biomechanical soundness is, and I find that interesting as well from a total hip standpoint.
From the femur, I hope we're going to publish quite soon some more work on the elasticity of the femur and the impact of a femoral stem on the biomechanical properties of the femur. And if you can save the compression trabeculae from the calcar going up onto the femoral head, if you can save those, then your hip flexors are just driving straight up them.
Yeah.
If you cut them off, they've got to go down into the femoral shaft to bond onto the metalwork and then go back up. It's a tortuous route for the forces to be delivered.
You mentioned briefly your detractors. Well, you said sort of jokingly, if detractors were finding these problems, of course, they'd be bringing them up online. I'm certain you must have run into some detractors during this development period for some reason or another. What are they saying? And has their message changed over time, or has it gotten louder or quieter? What would you say?
I think I've got to be polite. It's data, you know. There are big hip groups that publish huge amounts of stuff that have never published any outcome data, not revision rate, but actually outcome.
Yeah.
And if you look at the Swedish registry, and the Swedes have done a very good job of looking at how their patients are doing, not just revision rate, but everything else. In their registry, a cemented stem isn't that great. You know, functionally, in terms of outcome studies, they're not that great. And cementless stems seem to be better, but not as good as resurfacings in functional terms. Now, of course, there's selection bias and all that. Of course there is.
Yeah.
But no one's ever done the other way around. No one's ever shown that the resurfacings do really badly functionally. And so to say, I insist on cutting out your femoral head and fossilizing the inside of your proximal femur. So the big arguments in Britain, honestly, it's about cemented stems. Can you believe that? It's amazing. They really are devoted to that.
Is there, do you have any thoughts or plans on turning the H1 into sort of a smart implant or something that has some built-in sensors so you can understand maybe a little bit more in depth what the interface with the bone is like, what the load transfers are like, or any other changes to the biomechanical?
So, it's a really interesting question. I feel because you're just putting a coating on that femoral head, it behaves very like a normal femur. It really does.
Yeah.
And I think the thought of going through ethics and all the development pathway to get the strain gauges into something in the femoral head, I'm not up for that yet. I think when we've only got 7.5 year results so far.
Yeah.
And nobody thinks that's long term. I think if we absolutely know what the 10 and 15 year results are like, then I wouldn't feel bad about asking someone to do that. But for the moment, I think I wouldn't ask someone to have that done to them.
Thank you for joining me for this episode of the AHF Podcast. Be sure to join me next week for part 2 of my conversation with Professor Justin Cobb. Please take a moment to like and subscribe. You'd be helping us find more people just like you to share this content with. And as a subscriber, you can always drop an idea for a topic or any feedback you like in the comments below. You can find the AHF Podcast on Apple Podcasts, Spotify, or in any of your favorite podcast apps, as well as in video form on YouTube/@Anterior Hip Foundation, all one word. New episodes of the AHF Podcast come out on Fridays. I'm your host, Joe Schwab, reminding you to keep those hips happy and healthy.